Okay, so I want to welcome back Dr. Carrasquillo. He was with us for our very first Med Talk, so we're very honored to have him joining us again. And he's going to be giving us updates on the COVID-19 pandemic, the vaccine, boosters, all that good stuff. And then at the end, everyone will have an opportunity to ask their questions. And so I wanted to introduce Dr. Carrasquillo in case you haven't been able to join us before. For the past 10 years, he has been the chief of the Division of General Internal Medicine at the University of Miami Miller School of Medicine. And currently he is leading various COVID-19 projects, including the NIH-sponsored Florida Community Engaged Research Alliance against COVID-19 in disproportionately affected communities. So without further ado, I want to welcome Dr. Carrasquillo. Thank you for joining us again.
Thank you, Allison, and thank you for inviting me again. I forgot, when did I speak to the group last? I was trying to remember, but It
was a while ago. Do you remember?
Was it more than a year?
No, I think it was like about 6 to 8 months ago, if I'm not mistaken.
Was it after the vaccines came out or before? Do you remember that?
Before.
Usually how
Before.
Yeah, before. It was before.
When I think back of the COVID pandemic, I always think pre and post vaccine rollout, but it's two different things. But I start to, but again, thank you for doing this. I know it's a small group. I like an intimate group, which means easy to get through everyone's questions. So I'm really happy about that. The purpose of these calls is really to help us get out of these seminars, is to really help us as a global us get out of this pandemic by thinking, how we can end the pandemic or at least reduce it to smithereens, as I tell everybody, so we could go on with pre-COVID lives. Though there's something to do this and talk to you. I'll start with, let me put up my slides and then we'll go from there. Allison, I'll be monitoring the chat, but I think it's probably helpful because we are a small group. If anyone has any questions, just, pop them up. I have no problem being interrupted. Just pop them up. And we're supposed to go till 5 o'clock. Is that correct?
Yeah, we have 5 o'clock.
Yeah.
But if it goes a little shorter, maybe a little longer, that's fine.
Yeah. Okay. Yeah. Just want to know. And there's no other speaker. Okay. So let me just punch up the presentation mode here. First, let me share screen first. All right. You should see my share screen now. And okay. So you see COVID updates, correct? Somebody could just say yes.
Yes.
No. Okay, good. All right. And again, this is part of this group that we have called the Florida Community Engaged Alliance Against COVID. I mean, it's in disproportionately affected communities, but I'll get through in a second how that has really changed as the pandemic really rolled through us the last year than this year, specifically the last few months. But let me start with the numbers where we are, and I'll go from there. And again, feel free, anyone to put the questions, and Allison will go ahead and share them with me. A little bit of the talk outline. It's going to be slightly different. I moved the slides around a little bit, but this is what I'm going to try to get through in the next hour. So this is where we are. This is Florida. This is the data from Florida. And this is where we are in terms of the pandemic. Sorry. This is where we are in terms of the pandemic. And if this slide doesn't keep going back on me, and I remind people, so this was the Delta wave that we just got through here in Florida. And I put that in comparison in terms of numbers. This is where we were back in March when the whole world stopped, March of 2019, when the whole world was put on hold. And look at the numbers back then, and look how each of these waves has happened, and look at the Delta wave that just hit us, and see how terribly disproportionately affected we have been with a lot of these. So it's always put into perspective. But the good thing is that look where we are coming down. Delta, like we saw in many other countries, hits fast, hits hard, but then comes down very quickly. And that's what we're seeing now, that we're seeing a very, very nice drop in the rates that we have here. Not only the rates dropping, but the positivity rate for Florida finally fell under 5%, which we use as a rough marker of when we could start, thinking that maybe we're out of it for the short term. So that's a really good that we've also, not only the cases dropping, but the positivity and hospitalizations usually lag about a week behind the cases. And certainly we've seen a dramatic drop in hospitalizations. I don't even think Jackson sends us. We were at 450 at Jackson about 5 weeks ago, and we've dropped, I think it's now about 100 or less, but coming down very, very nicely. And that's obviously, deaths lag about 2 to 3 weeks behind that. And we've also seen the number of deaths disproportionately drop as well. So overall, it's a good picture of where we are now. But one thing we've learned from COVID is we can never, never relax and put our guard down, because every time we try to do that, we see these peaks come right back at us. So if we've learned anything from COVID, COVID will find any weakness in any of us. And this is where the rest of the country is. And again, I'm sorry, this is where the rest of the country is. And again, this is when the whole country shut down back in March a year and a half ago. And then we see this is the wave over the winter, and this is the wave in the United States. We got hit first, but the rest of the country is also coming down nicely as well. But we were the first ones that got hit in Florida, and we're the first ones coming out of it. This is where the hotspots are right now, and I just want to compare this to the slide from 5 weeks ago. But you will see Alaska, this is as of last Friday, Alaska is really being hit hard still, and other parts up here in the country. But we in Florida, again, the worst part of this Delta wave has passed us already. This is how we looked 5 weeks ago. So 5 weeks ago was us. We were the epicenter of the epidemic in the country again. And so we've gone past, but it's important to remember that this is what could happen almost overnight when we're not vigilant. And this is just on the Delta variant, which was what really led to the epidemic. We monitor, we get routine samples for both University of Miami Health System and Jackson, and we do genome sequencing to be what type of variant. So this was in July, where we knew the variant was circulating, and we knew we were going to get hit. We saw, this was in June, and look what happened. So we knew Delta, we saw a dramatic change in the virus that was attacking, and we knew it was Delta. We knew it was coming throughout July. We knew it was coming, and in August, we got hit really hard. So we do monitor for these variants. And as I'll get through in a second, the Delta, the main difference, it wasn't so much that it was a worse virus or more resistant virus. It was just way more contagious than any of the other viruses we had seen. But that was the main difference with Delta. It was the amount of rapidly spread, much more contagious than some of the other variants. And so that's what hit us these past 2 months that we're now recovering from. But it's useful to remember, this is overall, this is for the past year and a half since COVID began. This is where it's been hit hardest. And you will see that some of the hardest hit parts of the United States were actually here in Florida, and sort of the southeast part of the United States really, really got hit hard by this virus. Some of the places that were initially, the epicenters, like the Northeast, the West Coast, and even California, sort of this part, have actually fared much better overall than how we did in the southeast part of the country. And if you look at the recent deaths with the Delta surge, these are the deaths since June. And again, you will see that it was us, the southeast, again, who got really, really hurt really badly with this Delta wave. So, thank God we're much better than we were a month ago. So that's really positive. That's really good news. But again, vigilance is key. And this was an interesting article. People get bored when a doctor puts these type of graphs, but I'll just explain it in words. So listen to me rather than the graphs. So I'll try to do the graphs. But we know that COVID has disproportionately hit minority communities. And this was, if you follow excess deaths, as compared to what we expected deaths without a pandemic, these are the excess deaths by groups. This is whites, this is Latinos, and this is Blacks. And what you will see is that really, really, the epidemic hit minority communities much harder, including Native Americans over here. But what this little space here represents are the deaths not due to COVID. So these are excess deaths from other things that were not due to COVID. So a lot of this is the people that during the pandemic stayed home. They didn't want to come see their doctors. They were having chest pain, but were afraid to get COVID, and many other things. So it wasn't just a COVID-related deaths, but it was a lot of other things associated with COVID that also led to the sharp increase in deaths, which again emphasizes the pandemic. It wasn't just COVID, it was for many things that hit us really hard during that time. Okay, and then this is where we are with vaccinations. And this is the data from last week. I just took a peek again. But we saw, this is for Florida again. we've seen, and I'll go through the national slides in a second, but initially we do know, this is with a vaccine rollout, we do know it's problematic, but finally we got good distribution. I think, probably by the end of February, we're doing really well with production. We learned about distribution and how to do it best. And then we had a dramatic upswing through May in the amount of people taking up vaccines, but it really, really has tapered off the last few weeks. We thought we're gonna see a spike with Delta, that a lot of people be motivated to get vaccines. Unfortunately, it really didn't happen. So where we are right now, this number has actually increased to 72%. So 72% of the people age 12 and over are fully vaccinated now in the state of Florida, which is really, really good news. We're really happy about it. But the problem is when you have a virus that's super contagious like the Delta, 70% still falls far short. We probably need to be about 85 to 90% when we have something as contagious as Delta. So we're still a little bit behind where we should be in the state of Florida. When you look compared to the rest of the United States, and there's some states that don't have good data, but this is where we are in terms of vaccination. And here's Florida. So there's some parts that have been vaccinated much better than other parts. But in general, you will see up in the Northeast, and again, the Pacific coast that have done better than many of the states in the Southeast, that here in the Southeast, we have some of the lowest vaccination rates, which is really of concern to many of us. When you look at Florida, we will see it's different. Here, Miami-Dade, sorry. When you look at Florida, when you look at Florida, sorry for that. This is Miami-Dade County. We're actually 85% of those 12 and over. However, I think this is an overestimate, because we certainly have some people come here to Miami specifically from other countries to get the vaccines. So maybe this is a slight overestimate because they're included in the people who get the vaccines. But in general, Broward, Miami-Dade, and the Keys, they're all doing really well in terms of vaccination rates. However, the concern is up north, up in some of these counties in the Panhandle and the more rural counties where you have vaccination rates that are still under 50%. And I'll talk a little bit about that in a second, but that is where we are in terms of vaccinations. In Florida, we're doing well. Certain parts of Florida are doing really well, but other parts are still, need to get there. Initially, we were concerned about disparities in the minority populations. As anywhere else, you saw somehow the rich and the wealthy being able to get into the front of the line and get their vaccines first, and there were distribution problems, and minorities initially were sort of laggards up in getting the vaccines. However, we've seen, and this is national data, we've seen the gaps, this was Latinos, and the gaps really between Latinos and whites really, really narrow. This was Blacks, slightly behind, but we still need to keep an eye on it. So for Latinos, really no gaps, but still it looks like Blacks are still slightly less likely to get the vaccines. The problem with Florida, and I just put this slide up, is that the data the Department of Health releases now on a weekly basis is really not good, and there's many data integrity issues with it, so you can't track disparities for Florida as well as we can. So it is an issue, but at least the best indicators we have from many sources is that the minority gap in vaccination rates has finally begun to narrow, and for Latinos may already have been eliminated. So that's a good thing that we're doing in terms of vaccination rates. However, this is the part that we're concerned about, which what I call is the political gap now. As you saw the epidemic being made 100% political and all this politicization, vaccines sort of got substituted for party affiliation, which was very, very sad because we need everyone to be vaccinated. So here's some data on counties that voted for Biden versus counties that voted for Trump. Again, national data, but you see this thing that in April, there wasn't that much of a disparity, but as things have progressed, you see this widening gap by political party affiliation. Really, really sad how we made this into a political issue that should have never been a political issue. This is a Gallup survey released a few weeks ago, but showing among Democrats, vaccination rates versus Republicans, 92% versus 56%, and really, really shows a glaring gap. And, I'll be glad to take questions later on how we can address this. But it is of major concern to many people in public health because, again, we all need to be vaccinated. We can't write off a certain segment of the population. This is something that affects us all. All right. So I think I presented this last time, but COVID prevention, before we talk about the vaccines in terms of update, COVID prevention is extremely simple. One, avoid being exposed to the virus, and two, avoid exposing others. Like any other public health epidemic, this is how you control epidemics. So how do we do that? again, this is a cartoon, but I have to show it because clearly this is how people spread the virus. It's mostly spread through respiratory, through the mouth when you breathe out. And so this is how the virus is spread, depending on the particle size, how far it can be spread. But if you think about it, any elementary school kid can tell you, how do you stop this? Well, you put something here to prevent you from spreading the virus. And that's where the whole thing about masks come on. And again, something that has become political and extremely controversial. But you don't need to be a rocket scientist to figure out that mask is the best way to stop people from preventing the virus. Somehow along the mask debate, the debate just got totally that it was about protecting you from getting the virus, and masks do help that to some extent. But what masks really do is prevent you from spreading the virus. Because most people that have the virus, you're most infectious right before you start getting symptoms. So a lot of people spread the virus before they get symptoms, or sometimes, as I'll show in a second, you never get symptoms. About half the people never get COVID symptoms who have it. So the best way we could do this is by wearing a mask. And so whenever those rates start to pop up, when that positivity rate starts to pop up, those are where immediately we have to go to this prevention measure. And again, this is masks. I just used this slide. I think I showed it last time, but obviously masks have to include the nose, which is critically important. So many people I see not covering their nose with the masks. Tons of data about mask mandates and how masks work. This is one hospital in Massachusetts. I'll show a couple of slides, but this was before they went into mask mandates for everybody. And then what happened after they went to mask mandates for everybody, you started seeing a dramatic drop in the cases of COVID at that health system. So this is a health system related study. But then this was another study looking at states with masking mandates, without masking mandates, before the mandates and after the mandates. And we see a nice drop in the daily new cases only in states that had these mask mandates. So that's another example of how masks have been shown to work. This is another study in counties that took universal masking mandates versus those that didn't. And what you see is that once the mandates went into effect, these were the ones that had the mask mandates, these are the ones that didn't. And again, you saw much rapid increases in COVID in the states, in the counties without mask mandates. And you also saw that in each week, mortality increased in those counties that did not adopt mask mandates. And this was one that was just published not too long ago, at the end of September. This one's looking in schools, at schools with mask mandates and without mask mandates. And in those schools that did not have a mask requirement, they were almost 4 times more likely to have COVID-19 outbreaks. So masks definitely, despite politics aside, and again, I'm just speaking from the science perspective, not the political perspective, but speaking from the political perspective, masks do work. And they're most effective at preventing a person from spreading it. So the whole debate about masks, I'm not sure I got railroaded into politics, but the whole debate about masks is preventing you or the kids going to school from giving it to other kids. It's, protection is great, but it's much more about preventing it from being spread, as that cartoon showed. So that's one of the ways that the crisis really got politicized. And again, I'm not going to say much about this, but we keep trying to put politics into it. I mean, our governor just picked a surgeon general who was very critical about mask mandates, despite the strong data in support of masks. So it continues to be a politicized issue, which is really sad because it never should have been there. I'll stop there. I'm going to go through some of the recent data on the vaccines just to show how it works, but I'm speaking and rambling. So I just want to stop for a second and see if there's any. Allison, is there any questions yet? Let me stop sharing for a second.
No questions yet in the chat box. Again, a reminder, if you have any, please feel free to put those in the chat box.
Okay. I'm going to talk about the data for the vaccines and misinformation, but anyone have any pressing questions on what I was asking until now?
I have one quick question based on what you said, Doctor.
Mm-hmm.
Can you hear me well?
Yeah, I can hear you perfectly.
What measures can be taken, especially by advocates and people in the nonprofit sector who are doing popular education and awareness campaigns, so that people who don't have COVID but they may have other chronic disease to go out and seek help and get back to their treatments, so that we don't have this excess deaths? I mean, what are some of the things that we could do on our end?
Well, first of all, about seeking treatment, I mean, most of the healthcare systems are back opening at almost full capacity. I mean, there were some issues about visitors at hospitals still because we're very concerned about people spreading COVID, you know, and people that are really, really sick in the hospital for many reasons, of which COVID was just one. We had all the other sicknesses were still being admitted. That's been relaxed. But most of the clinics throughout, you know, are back open. I know in our healthcare system, our clinics are open. There's still visiting rules, right? So people with disabilities, one of the things I usually have to intervene is when one of my patients comes in and needs somebody to accompany them, making sure that the staff downstairs knows that they please allow their visitors. So it's critically important. So nobody should be going without needed care at this point. I think that's the main thing for anybody, because that's key. That was, you know, that quarter deaths that were non-COVID related was people delaying care because of COVID. But beyond that, I think it's all our responsibility, unfortunately. And I'll talk a little bit about how to talk to people that don't want the vaccines and don't want to wear masks. But it's all our responsibilities to try to promote that in appropriate ways. There's ways that we should not be doing this, and I'll talk in a second how to talk to people that are hesitant. But it's also a rules to try to be ambassadors because, you know, there's certain high-risk groups. I mean, this group, for example, is a high-risk group, and we really need to do our best to protect them because, as I'll show in a second, vaccines are not 100%, unfortunately.
Doctor, I have a question.
Yes.
Back on the mask. I notice now since you know, we're going through this process where you know, more people have been vaccinated, and now businesses that had required masks to enter are kind of lightening up on that requirement. They're not enforcing that. So now we have a situation where many vaccinated people will be going into the business, let's say Publix, because that's where I see it, you know, all the time, or I experience this.
Right.
So you'll have vaccinated people coming into Publix now without the mask because they're vaccinated. And then you'll have people like me who still wear our mask in Publix because I feel safer having the mask. Even though, you know, I'm fully vaccinated, I still wear it because I just feel more protected.
Yeah.
And so I'm assuming, seeing all these people without masks, I'm assuming, well, they're not wearing masks because they're vaccinated and they feel confident. And yet, at the same time, I know among those people who are not wearing masks, some of them are not vaccinated, you know, but you can't tell, of course. So how is this going to shake out over time where businesses they're getting lax about that enforcement, and then we're going in there and you can't assume everyone is vaccinated who is unmasked. And, you know, how's that dynamic?
Yeah, no, I understand. And the problem is what I hinted before about politics. This should strictly be, what you're asking is strictly a scientific question, not a political question, right? So there's certain things you know, people as epidemiologists follow that they go by. Most importantly is the vaccination rate. So if you see Miami data, assuming we believe the number is 82%, which, you know, again, but it's probably somewhere above, definitely above 70%. And I'm hoping it really is close to 80%, right? Then you follow what the positivity rate is, right? So usually under 5%, that gives us, once we drop over 5%, we have assurances that things are getting better. So the vaccination rate, positivity rate, how many new cases are being diagnosed, if it's going on the way down, and also how infectious, like these variants, you know, you have to have a much higher threshold with something like Delta that's much more infectious. And you would have scientists come and give you, okay, look, based on these numbers, I think we could start relaxing some of these mask wearing, you know, requirements. And this is where we are. The problem is that it becomes so political up in states like Florida, where that process does not exist, right? And you have people making decisions not based on science, but based on politics. Based on the numbers I see here, I think it is time to start relaxing. But again, you have to be very, very surveillant. I think some of the super tight controls can start to be relaxed. But if you're asking me, the question is, am I at high risk and am I vulnerable? Masks do protect. They're very good at preventing you from spread, but they also protect. Absolutely continue wearing the mask, because you cannot assume that everyone's vaccinated. And even people that are vaccinated can still get the virus. But that's where I wish science was dictating this. This is what before, and, you know, a time before, you know, science became political, you would have county departments of health monitoring this data, making decisions on a county by county level. This is where the numbers are, and this is what we think. Unfortunately, that did not happen. That's why, you know, we've lost over 700,000 people, because we did not follow the science. We decided to make this political.
Right. Now, about the mask, could you address this? I noticed when I've gone to health care facilities, doctor's offices, if they make us take off our cloth masks and they replace them with the paper procedure masks. And so, can you distinguish what's
disposable? Yeah, you want a fresh mask. You don't know where that other mask was.
Oh, is that? I thought there was something about the paper procedure mask was better qualitatively. That's not the case?
A lot of the population level epidemiologic data that was collected was on cloth masks, right? We don't know what mask you're bringing, if they're really dirty, if they're good. I mean, we've seen people wearing mesh masks, which are not good, and think, hey, this is a mask, for example. So it gives some sort of uniformity. Everyone's wearing a mask that we know it's good. We know that it has a tight fitting, that's not just open in your nose, so you're still getting all that out. So it's the way that we guarantee that everyone's wearing a good mask, because there's no quality control.
Okay. It doesn't mean that the cloth mask was necessarily bad.
No, I mean, if it's a regular cloth mask, those work fine, but people are just poorly wearing, poorly fitting things that should not be masks, for example.
I see.
Good. Okay, let me move on to the next part, which is, again, let me go back to share screen, which is the vaccine data. Okay, so this is, we initially, these vaccines got approved with 3 months worth of data on the emergency use authorization. And now we have vaccines like Pfizer that have already been fully approved, and all the others are very much almost there already getting it at. But this is a follow-up data from the Pfizer vaccine. They continue to publish data for 6 months, and you will see that vaccine efficacy is still at 6 months, very, very high, much better than any other vaccine. But the most exciting part is that at 6 months, you have over 95% vaccine efficacy against really severe disease. So this is published data from the vaccine trial showing that they continue working really, really great. So that's really good news. What you will see here in terms of numbers is that these are the numbers after the vaccine in terms of severe disease. And what you will see, it's 81 versus 873, for example. So major, major protective effect in the two groups. And then what, very exciting, which not always happens in medicine, but so we're really excited that happened here, is the data from the real world. This is one of the first real world studies among healthcare workers. The ones number of cases among patients, healthcare workers who got vaccinated versus unvaccinated. And yes, some healthcare workers were laggards in getting vaccinated. But compare the results. This was following a large number of healthcare workers. 3 among those that were immunized, 161 among those that were not vaccinated. So again, tremendous, super high among fully immunized, 90% effectiveness rates, which we're really, really happy that in the real world it came out that way. We've also followed the side effects. This is, again, the real world data on side effects. In general, the orange is the side effects from COVID. So, kidney injury, we know, is one of the long-term effects of people that get COVID. So this is with a vaccine versus without the vaccine. And this is the one that scared some people. This is the rate, basically, it's about for myocarditis. People who get vaccinated, it is extremely rare, mostly young men who get vaccinated with the Pfizer, Moderna vaccines. You used to have a slight increase in myocarditis, but this is the risk of myocarditis from getting COVID in of itself. So the risk of getting even myocarditis is much higher when you get COVID than it is with the vaccine. But for most other things, this is for blood clots, heart attacks, deep venous thrombosis, because COVID itself causes a lot of coagulation problems. So with the vaccines, we know that it is much protective. The one issue was with the Johnson & Johnson in terms of blood clots. We did see it in women of childbearing age. Again, we're talking about stuff 1 in a million or something like that. And when people are really worried about it, I would say, well, try one of the other vaccines if you're concerned about the Johnson & Johnson. But in general, we know from long-term monitoring, these vaccines are extremely safe. Allergies, which you were really concerned about, extremely, extremely rare. And most of those are, only 4 patients of 190,000 doses actually got hospitalized and no deaths from allergies. So we've done really well in terms of monitoring for allergic reactions as well. This is recent data about the vaccine effectiveness in the real world. Now, this is the number of cases, the rate among people that are not vaccinated. And this is the number of people who got COVID who are vaccinated, which again shows that you can get COVID after being vaccinated, but it's extremely less. But in terms of severe COVID, people being admitted, look at the unvaccinated versus those that are vaccinated. So, the message from this study was if you're unvaccinated, you're 5 times more likely to get COVID and 20 times more likely to be hospitalized for COVID. So vaccines extremely well, but they're not 100%, which is a message I hope everyone understands. This was a study out of the VA system with the Delta virus. This was the rise in the VA patients in Delta. And you will see that through June, it was not there. And then suddenly we had this dramatic rise in Delta, which I showed you in another slide. So this was a virus that was circulating among veterans in July and then August. And this is how effective the vaccine was. And now this is the point when Delta was circulating, it was 89% effective. Again, this was the Moderna vaccine. But again, very, very high rates of effectiveness against the Delta. And very high rates, among all groups. So overall, it was 87% effective in this study of veterans. So again, good news that we like to hear that the vaccines in the real world turned out to be as effective as they were shown to be in the randomized trials that were done last year. This is, again, following people after the vaccine. And you do see, again, this is people getting COVID. This is placebo, and this is the vaccine. So you do see how well the vaccine protective effect is. However, one thing we did start to notice, if you see here, is, after long term, you do seem to have a slight drop, particularly among the elderly. You do have a slight drop in vaccine effectiveness, which was of concern to some people and led to this thought about boosters, because it looks like maybe after 6 months, particularly in the elderly, you see this drop in protection. In the Johnson & Johnson study, which I know this is internal data because I participated as one of the investigators here at the University of Miami over time. We did see really high efficacy at preventing deaths and preventing hospitalizations, but you do see this episode again of slight waning of immunity and decreased effectiveness over time. And at the second dose, again, Johnson & Johnson was the vaccine that's only 1 dose. And with a booster dose, you do see a dramatic increase in titers and potentially increased efficacy, which is where the thought of the boosters comes in. Johnson & Johnson submitted their data to the FDA to get approval for a booster. Pfizer has been approved. And this was some data from Israel, again, suggesting that with the booster vaccine, it did increase, by a factor in terms of vaccine effectiveness, because we saw the slight drop after 6 months, particularly in the elderly. So this is the data that we have in support of boosters. And I may have dropped the booster slide, which it's unfortunate, but basically, so I'll just use this. But basically what we are now saying for the boosters, right now the only booster approved is the Pfizer vaccine. Moderna and Johnson & Johnson are going to come up anytime soon. So if it's 6 months after your second dose, if you're elderly, you're in a high-risk group, which many in this group probably may be. And so it's critically important that, start getting that booster. Again, those are the high priority groups for me right now, elderly and people with complex medical conditions. They should definitely be getting their booster. Other people who feel at their risk, for example, healthcare workers or something like that, should probably get another booster at some time in the near future. But the ones that absolutely should be getting the booster, the elderly and those with multiple conditions. And then the other boosters from Moderna and Pfizer are coming soon. Right now, we're not recommending combining boosters. I know some people are doing their own little cocktails, and all 3 companies are very interested in studying. I know in J&J, we're tracking down whoever got one of the other vaccines as well and keeping those data down. Preliminary data suggests that it may be okay to get boosters from another one, but right now, I'm telling people stick to the vaccine you got for your booster. There's no shortage of vaccines right now, and certainly if you got one, that's what you should be getting your booster with. Then this is other data for other treatments for COVID. Right now, we don't have any really good treatments, but this is the antibody cocktail that people have been talking about, and it does reduce it. In the subjects, this were people who had a mild COVID outpatient that had COVID for 3 days or less on average. And of those that got the cocktail infusion that we call, the rate of infections, being admitted, for COVID, was 1% among those who actually got the cocktail versus 3% of those who didn't. And and again, shows some good protection, risk reduction of 70%, but in absolute terms, 1 versus 3%. So they do help, these antibody cocktails. They're not a panacea. Certainly the best thing is to get vaccinated. That's absolutely the most important effect that you will see on this. But for people that do develop COVID, if you come in early enough, you can get the antibody cocktails, and they do seem to work. Now they even have the cocktails for people who are just exposed but are super high risk of getting bad COVID. And again, this is comparing, again, people getting actually infection who were exposed to somebody with COVID, placebo 8%, with the antibody cocktail 1.5%. So again, people at high risk who got exposed, if you want, we can do this antibody infusions right now. It's extremely easy to do. There's many centers around the county where you could get these infusions as well. So that's another part of it in terms of COVID. And we continue doing, excuse the typos, we can continue doing clinical trials, even though, the pandemic is waning. For example, we have many examples of things that didn't pan out, like hydroxychloroquine. Very good studies showed it didn't work, so that's good. But we still have ongoing studies. This is one we're doing now here at the University of Miami, comparing different treatments. One is placebo. One is an inhaled nasal steroid. We think that by decreasing the inflammation in the nose, we may potentially be able to decrease the amount of COVID that people are getting. But there's other things, even ivermectin, the much touted ivermectin, that's even been studied. As you know, there's a lot of people who, based on very flawed data, started taking ivermectin. And not only that, they were taking it at veterinary doses, which is extremely scary. They were taking doses that were used for cows and for horses, led to a lot of problems. But the data, it's still, there's no good study showing it doesn't work. It still needs some research, but clearly it's not something people should be doing on their own. This was a recent review. I'm sorry, just close this. But basically there's a lot of really misleading evidence on this, on ivermectin. And so we need good data. So that's one of the studies we're trying to do here. It looks like it may not work, but we still need a formal research like we did for hydroxychloroquine showing no, ivermectin doesn't work. So it's still an open, it's still not an open shut question. It's still an area of research to see whether it does or not. And finally, I'll conclude before I stop. The other thing we're very concerned as doctors is what we call the COVID long haulers, the people that still have symptoms long after most COVID goes away within 2 to 3 weeks. But people have, the easiest example is a cough. We've always known that when people get lung infections, sometimes get a persistent cough that can last for weeks or months. Getting back to smell and taste, that's something also that it takes sometimes months and months for people to get back, and some haven't recovered fully. But there's other effects. Some people seem to have persistent fatigue months and months after their COVID, and that we don't have a good handle on. The effects of the heart of COVID, I mentioned myocarditis is one example. People with COVID that will get this, and some people seem to have, persistent inflammation of the heart for a long time. Some people get some psychiatric effects that seem to persist for a long time. Kidney damage happens in people with COVID. And interesting, there's something called a POT syndrome, which is basically fainting spells with drops in blood pressure. Some people after COVID have begun having fainting spells, and we still don't have good numbers. There's a lot of studies going on to try to find out about this and what may be the mechanisms, but there's still a lot about COVID that we don't know that we need to do research on. And I'll stop it there for questions. The last part is about COVID misinformation. So let me just take another pause, stop for questions about the actual updates on COVID, and then we'll talk a little bit about the misinformation that we're seeing out there.
Dr. Carrasquillo, I have a question. You went over some of the products or treatments that are in trial right now.
Correct.
And one of them was the one, I believe, that the nasal spray.
That's
right?
one of the ones that we're studying, correct, yes.
So I have a question about that because I was asking a doctor a few weeks ago what was the best way, because I'm Brazilian, so what's the best way to help everyone in, my family in Brazil, in the communities in Brazil. And he said that the best way would be to buy the nasal spray. And I'm not sure if it's the same one. He was explaining that it's like an herbal mix, and that like when you spray it, it's not, it's like effective for maybe a little bit, I guess, like the time that you're in a grocery store or you're going out in public. Is that correct? And what are your thoughts on that? Because it seems like with masks and vaccines, it would be like the best thing to just put your efforts into that rather than this nasal spray. I don't know.
So absolutely, mask and vaccines are the main thing, and obviously social distancing. If you have things like that, those are those are the proven methods, right? That's what we really push. But there's ongoing research. And by the way, I forgot to mention the new pill from Merck that will probably be coming out at the end of December. There's some really promising data about that pill as well, which I did not include. The problem is that sometimes people get ahead of the science, right? And there's something published in some rare thing. That's what happened with ivermectin. But we as doctors, when we say things, we say, yes, this is definitely clinically proven, and then this is my opinion. And too many people sometimes mix opinion with what's clinically proven. For me, something that's clinically proven is that vaccine studies, we get 20,000 people, we give them the vaccine, 20,000 we don't give the vaccine. We follow them for 3 months and we see who developed COVID. That is hard data. You can't argue with that, right? That's clinically proven. The FDA reviews the data and the team of scientists said it works. And then there's people's opinions, which is what's really hard. Theoretically, if you decrease nose inflammation, and I don't know that spray he's talking about, but the ones here are nasal steroids, that may work, but you don't know that. You have to do the study and you have to, so one is the opinion. One example of the opinion is in Brazil, because you mentioned Brazil. One of the concerns that they're getting the Chinese vaccine, right? And the Chinese vaccine may not be as effective as other vaccines that are licensed in the United States. So people are coming here and getting that. And people are asking me, should I do that or not? And I said, there's been no good studies comparing whether getting a regular vaccine after the Chinese vaccine, is that dangerous? Is this not? And I say, so that's my medical scientific fact thing. However, my opinion is that if somebody got the Chinese vaccine in Brazil and they happen to be in the United States and you get one of the very effective, it's probably safe. That's what I would recommend to one of my relatives, for example. But that's just my opinion. That is definitely not based on science. And sometimes people slip the two, so we don't know about these inhaled nasal steroids. We do know masks work, and that would be the number one. Getting vaccinated, even if the Chinese vaccine is not as effective as the other vaccine, certainly do that. And if you can get a better vaccine, even better.
Thank you.
I have a question, Doctor.
Yes.
I was speaking with a senior recently who told me that he, before getting his third dose,
Mm-hmm.
he wanted to know how much his second dose had waned.
Yeah.
And he went to a private practice and got an antibody test, I guess, which gave him a percentage of where he was at. So he knew, how much his protection had waned prior to getting his third dose. Is that's not routinely done. I know most people have no idea what percentage of protection they have.
Recommended, and there's no threshold, but people will come to me all the time. So first of all, we don't recommend checking antibody titers at the vaccine to begin with. So for most people, they don't even have a reference point. And before, we were just reporting positive and negative. Now some of the companies are starting to give us antibody titers. The problem is we don't know what the right level of protection is for a person. So I tell somebody, okay, these are your titers. It was 1 to something, whatever that means. And then they ask me, are you protected or not? And I say, well, I don't know, because we don't know what the threshold is. It hasn't been established, and there's no FDA approved test to do that strategy. But I have a lot of people who ask me, I guess because they keep bugging me, I'll do the titers and I'll tell them, these are your titers. And they're like, should I get a booster or not? And I say, well, if you got the Pfizer vaccine and you're eligible now, you're at high risk and you're elderly, you should definitely get the booster. Or if you think you're at high risk. And they say, well, you would have told me that even if I didn't have the antibodies. I said, that's correct. That's why we won't recommend them. But many people got convinced they still want to see, their titer, but we don't know what that means clinically. You should still get the booster regardless of what your titer is.
I see. So that's not helpful at all. There's no reason to do that.
People want to see a number, but if they bug me enough, I'll order it. But for me, it's not helpful.
Yeah. Okay. Thanks.
All right. And so I have 10 minutes. Let me talk a little bit about the misinformation, because that's also, I think, important. Let me go back to sharing. Okay. And this is my big concern, obviously, on COVID, which is the vaccines will only work if you take them. And this role of misinformation, which you've all seen. And there's two parts to it. Misinformation is what we call incorrect or misleading information that people spread really without malice. One example is a vaccine was developed in 10 months, cannot be safe. First of all, it wasn't developed in 10 months. The technology has been, developing for 10 years. But nevertheless, this is somebody's opinion of this. And again, it's an opinion, a poorly informed opinion, but it's misinformation. And then this is what really concerning, which is active disinformation. And that we currently have. This is deliberate false information that is being deliberately spread over mostly through the internet, through social media, Facebook, Twitter, but then becomes the life of its own. And then you see the press covering some of this, but really main disinformation. What you're seeing is incredibly sophisticated, extremely well-known campaigns actively seeking to disinform people. And that's the part that really gets us. They know exactly who the audience is. I've seen so many videos targeting African Americans, very culturally appropriate, very well done. I've seen them for Latinos and extremely well done. I work obviously more with the minority populations, but targeting more I guess Republican oriented audiences. They prey on their fears, they prey on their distrust, and they make really, really good disinformation targeting them. And these are people actually trying to start trouble. This is not somebody who just doesn't know any better. These are people that know, and this is an active campaign that's happening to our nation. And I consider it an assault, basically. It's an attack that's happening to our population. We know who some of these people are. These are people that know better, and they're still actively spreading disinformation. I've done some shows where I'll pick one of these COVID misinformers, and I'll, show all the things. This is one example, Dr. Sherry Tenpenny. I just picked her because a group just asked me to talk about her not too long ago. Extremely grandmotherly. She is a doctor. She uses medical terminology. She's extremely engaging, extremely communicative, excellent, great communication skills. Looks like a very trustworthy grandmotherly. Unfortunately, a lot of what she's saying, doesn't make any sense, even if you're not a doctor. She'll talk about, I'm a scientist, I'm a researcher, but she's never published anything scientifically. Most of what she publishes is in her own blog file. I have lots of data, but I lost my files in my thumb drive, for example. And she always has some facts mixed in, but she'll say things that are totally, we know all the data on all vaccines. It's not just COVID, but all vaccines is based on one paper, which is ridiculous. The mRNA vaccines were never used on humans. We have trials from a couple of years ago on mRNA for other conditions that were used on humans. And she's like, since we started giving vaccines to the kids in 1990s, I'm like, no, I got my vaccines in the 1960s, for example. But anyway, so there's stuff that's totally off the whack that if you analyze it line by line, you could go through. But these are people that totally know better. And for whatever personal gain spreading this misinformation, this is another meeting. This is a doctor who, again, sounded very professional and explained, very simple, complicated medical concepts with ease, and said basically that the NIH and CDC are totally wrong, but contrary to science, NIH. So totally, and everyone applauded. Everyone thought this guy was great. 5 million views, a guy who's deliberately spreading this disinformation. And that's what people are hearing and seeing. And some of this we know comes from other countries, Russia being one, but a lot of it comes from Latin America as well, targeting the Latino population. And these are campaigns deliberately trying to, basically sow distrust, sow misinformation, and leading to the crisis we get. There's a good reason why we were one of the worst countries in terms of COVID, and it is because of this, and we see that still playing out politically. Then we have this kind of stuff, Nicki Minaj, and again, I don't think she did it purposely, but thinking how many followers, she said that the vaccine led to swollen testicles in somebody in Trinidad, and they looked at it, turns out it was never true, that never happened, and she was like, oh, well, a friend of mine's told me, so I thought it was true. And you're like, when you have so many social media followers, you cannot be spreading this kind of misinformation. I mean, it's just very, and you'll see this happening all the time. This is a private school in Miami that if the teachers got the COVID vaccine, you're not going to be allowed to return next year. Why? Oh, well, we thought that some women were having problems with their periods after the COVID vaccine. But that was never published. That's never happened. Where do you get the data? Oh, well, that's just what I heard. Again, a lot of this misinformation and disinformation, extremely deliberate. And every group, it's targeting very different people, and it's not monolithic. We've done some focus groups in different ethnicities, and we see for Latinos, for example, a lot of the disinformation is around sterility. How many women think that if you get the vaccine, you're not going to be pregnant? We've done some really good work overcoming this. The government tracking devices, the Black community, a lot of misinformation with the 5G towers. This was somehow the Trump vaccine, which, because, obviously he was the one that led to the initial investments. Among Haitians, there's been videos targeting the Haitians that they'll put a microscope under the vaccine, and you will see under the microscope the number 666. telling them, look, this is what you inject. You're actually injecting 666, and it's the mark of the devil. And this is the white population that doesn't want you to go to heaven. So don't get the vaccine because they're giving you this, or it's going to mutate into other organisms. This is some of the stuff we've heard from our groups out there. Some of this is dying down, and now we see it less in the minority communities. We see it more, in more Republican type audiences, but they all pray on the same thing. They all pray, this is what we call, one is complacency. This is the young people that I was admitting a few weeks ago to Jackson, where they just didn't get the vaccine because they just didn't think they were going to get COVID. But this is the one that really is attacking a lot of disinformation, which is confidence. You got to develop, if you're going to attack the country, you got to develop a campaign that basically challenges the trust in the vaccines and the trust in healthcare authorities and systems. And this is exactly what the disinformation from other countries as well as domestic is doing right now in terms of this is exactly, they know the models, they know how to attack it. It's very, very targeted, very weaponized disinformation that's coming at us right now. And they know how to pray. There's a lot of reasons. Many of us have fear, mistrust what's going on. There's been many known historical abuses against minority communities. A lot of people are going through very difficult times financially, obviously making it political, having political leaders, taking sides on something, not on science, but based on what party. All that just sows mistrust and makes a ripe environment so that then you could have misinformation, but most critically, disinformation campaigns that we see that. And that's what really concerns us. Battling it has been my charge for the last, year, trying to find out against these well-organized, highly sophisticated bad actors trying to do this. And the fact is most people don't want to spread this. They don't deliberately hit Twitter to spread something they know it's false. They're just so scared. It's so emotional. They read something, oh my God, I got to let the 500 people on my Twitter or whatever it is know about this because they don't know it. And they hit send without really thinking where that information is rolling. And we need to have, stop this. And that's our role, I think, for all of us. We do some training for frontline healthcare workers. I'll just give you a little bit of an example of what we do. No strategy can work, but, we got to develop these multi-tiered strategies. Obviously, if somebody wants a vaccine, that's great. If somebody's hesitant, you got to start a conversation, motivational interviewing. Oops. Sorry, I don't know what happened here. Give me a second. But basically, I don't even need slides anymore. The training that we do is don't dismiss people outright. You have to engage them in conversation. Don't tell them you're crazy. You should stop reading that Twitter. You should stop reading that Facebook, or you guys, you don't follow science. You don't follow knowledge. You got to engage them in conversations. What is it that, is concerning you? What is really at the root of this? And try to talk to them and understanding you're not going to get to somebody who's absolutely, no, I'm not getting this, to say yes with a 3-minute conversation. It's a long-term dialogue. There's certain ways you could talk to people. There's certain words you can and can't say. And that's all part of our training, how to really talk to these people and address misinformation, disinformation, but understand it's a long process. It's not something that you can do over, a few minutes or something like that. And it's hard. It's really hard. I've done talks about messenger RNA vaccines, and hey, this just came out of nowhere, showing them papers from, 2000, or I would show you the pictures, papers from 2018 about what's known about messenger RNAs and how they work, and say, hey, this is 2018 pre-COVID. And people tell me, Dr. Carrasquillo, that's fake. That doesn't exist. That's fake news. That was never published. I'm like, yes, you can go to the library. You can read the article that was hard print. No, they just snuck that into the journal later on. That was never published. And so it's really hard to fight these type of people, I would say. And it's one of the challenges I do have, in terms of addressing this. And with that, I see we're almost at 5, so I do want to take some minutes. And again, we do this whole training, but it's an hour session that we do, how to fight some of this. But I'll stop it for questions.
I have a question. Is that training only open to healthcare workers?
No, I could send you the slides. We actually train for lay health workers. So these are people with minimal medical knowledge that we train. We call them frontline workers. So a lot of community leaders and a lot of the people. Allison, if you want, I have it. I could certainly, it's with Lisa Hamilton. She runs the Florida Community Health Worker Coalition, but she's like me. She wants everyone to get this, and I could send you the slides. And they're good about how to address this.
Thank you.
We're all very concerned about this because, you saw the numbers and you see what's happening.
Are there any more questions from the audience?
I know that we're almost done. Well, it's almost five. It's 5 o'clock already. But I do have one question that we got from the public, doctor, and it's about self-tests. We have some homebound consumers that we serve, and they're interested in receiving self-tests at home. If you do recommend, which ones do you recommend them taking?
Actually, I haven't looked at that. I know some of them have undergone EUA approval and they're available in the pharmacies. Usually they're coming from the pharmacy. Those are probably the ones that are EUA approved, and those are fine. However, I have seen a lot on the internet, people selling tests that are totally bogus. People are just doing this. And so you have to avoid a lot. I mean, it's just hard, you know, to know who's true and who's just taking advantage of this situation. But generally you buy it at one of the big name brand pharmacies. They're not going to kid around and sell you stuff that's bogus and not real. But try to avoid buying, you know, that $5 test kit over the internet. You know, that's probably not a good way to go.
Thank you.
Great, so we are at 5 o'clock. So thank you everybody for joining us today, and special thanks to Dr. Carrasquillo for coming back. This was super informative, and we will definitely keep in touch with you. I would love to receive those slides. And that was a big thank you from CILSF. And Camilo Mejia, do you want to say a little bit about the Enable project?
Certainly. Thank you, Allison. Thank you, Dr. Carrasquillo, for a great presentation. And just to let you know that this is also part of the programming that we have at the Enable Project, which is basically a coalition of organizations that are trying to increase access and inclusion in social justice spaces and civic engagement spaces, and then pretty much in every space we can think of. Right now, the pandemic is the big driver for change, for you know, changes in public health, changes in the economy, changes in how we protect ourselves and our communities. And so this series of Med Talks, you know, have been tremendously helpful. And we thank you. We're going to have more programming coming up in the near future. And we hope to see you again. And we hope to get those materials so that we can share them with everyone. Thank you so much.
And big thank you to our ASL interpreters.
Bye, guys. Thank you. Bye, everybody.
Bye, everyone.
I think